Insights from the world's best medical minds. You are watching TheRightDoctors.com.
That you stay on to welcome questions. It is my pleasure now to invite Professor Dhruva Chaudhry, Professor and Head Pulmonary Care Medicine, and he was awarded the prestigious Commonwealth Academic Staff Fellowship in Pulmonology in 2009. He's also a recipient of the Ansraj Nair Memorial Award of the Indian Society of Critical Care Medicine for Best Researcher. We now invite him to share with us the experience from Asia. Professor Chaudhry, you have the floor, sir.
Yeah, good evening, everybody. I hope I'm audible and my slides are visible.
Excellent. Your slide is audible. Your slide is visible and your voice is audible.
Thank you so much, Dr. Akin. Now, it has been a pleasure actually listening the experience of managing COVID-19 from Africa, from Caribbean, and now I'm going to give you a bit of a perspective from the Asia and particularly from the India where we are going through this epidemic. And next 15 minutes I shall be discussing about it. And I'm also grateful to Indian Medical Association for giving me a chance, because this epidemic which has come up to us has been targeting a couple of major cities, including our capital Delhi, also our financial capital Mumbai, earlier a city of Indore, as well as in city of Ahmedabad. And they are a very densely populated city and has created a unique challenge for us. Therefore, Alex Hallis said it, either you deal with what is the reality, or you can be sure that the reality is going to deal with you. I think that's an extreme prophecy, which is true for COVID-19. When you start looking at the story of COVID in Indian subcontinent, first of all, the first case we reported here was on January 30th. That was from the state of Kerala. These were the young people who had shifted from China and who were studying there. But nevertheless, we had seen 3 cases at that time, all in the city of Kerala, and it's a huge country. And right from Delhi, it is roughly around about 200 kilometers. But nevertheless, it helped us waking up our public health responses. And that was one of the major reasons that we saw 3 waves which came to us from China, from the Western Europe, and later on from UK and USA. We were able to handle it, but somehow, somewhere in the middle of March and April, in beginning of April, we did lose some control. And there's just so much of variability within this country. Kerala and Goa still continue to do extremely well in India, whereas in Mumbai, in Delhi, as I said, in Gujarat, we are facing quite a lot of problems. When you start looking at the statistics, we are a huge population and a density. You look at it you compare to USA, Spain, Iran, we are nearly to them roughly around about 10 times. Therefore, for us, major challenge is how to take care of and prevent the spread. And if this illness goes into community, how to take care of the deluge of the patients if it come up, because even the best of the centers in US as well as in Italy, they found it wanting in spite of best infrastructure which they had. So that has been there, which you see. If I look at the current scenario, that is still yesterday, we have roughly nearly 6 lakh cases, and we had 17,000 deaths, which have been reported from various parts of the country. But dominant again is coming from the city of Mumbai and followed by the city of from the state of Gujarat and partly contributed by Delhi. In this case, if you see the various zones of WHO, primarily we are looking at Southeast Asia, and we have more than nearly 8 lakh cases which have been reported, and some part of Western Pacific just come up, especially if you see it in this case, there will be Malaysia, there will be part of Indonesia, Philippines, they're also covered. As far as in this case, Eastern Mediterranean is concerned, Pakistan comes into that and Afghanistan comes into that area, but geopolitically, they are part and parcel of Asia. There again in Pakistan, we are seeing an upswing, which is there. This is the growth of COVID-19 in Southeast Asian countries. If you see it here, if you see the countries which have been successful in flattening the curve, which was shown so elegantly earlier, one of my speakers have been in Sri Lanka. In Indian context, we have been able to take care of the beginning. And again, when you see the doubling time, it went up, and you are seeing a peak which is coming up, which is little which is steeper, but still not as steep as what we saw in Italy. And the doubling time in the India as of today is around about 17 days now. Same pattern has been followed by the deaths, which you see, whether it is in Sri Lanka has obviously minimal number of it. We are seeing a large number of deaths which are coming up. That's why the gap you will see is going up. But other countries also are seeing an increasing mortality with an increased number of cases. But what is reassuring to us is, if you see it today, in the world we have nearly 1 million, you have got more than 10 million people who are suffering from COVID-19. But and the deaths have been nearly 5% or so. But here in Indian context, if you see it, if the 5% is the mortality in the worldwide, we have 3% mortality. And again, it is varying from different parts of the country. Now, this is a huge country, and if you see it, the city in the state of Gujarat, we have more than 5% mortality, and there have been increased mortality in the states of Maharashtra and Madhya Pradesh, which are the very big states here. But dominantly, again, if you see, it sticks around to Mumbai. But the good part is that we are also having nearly 60% plus recovery rate is there. And the cases per population, when we started looking at it, India still has got per 1 lakh, only we are seeing roughly around 21 cases. That means the lockdown which was done in this country, which was unprecedented, I've never seen in my 50 years, 55 years of my life, never seen it ever. It has made a huge difference in terms of delaying the peak and also blunting the peak, as probably we would have seen it. Similarly, you look at the deaths per lakh of population, it still continues to be much lesser than what you have seen, whether you have seen it in the UK, you have seen in Italy, Spain, or even in the USA. So probably the public health measures, which are very strictly taken by the government of India and also equally supported across the political spectrum by the various states, because the states itself are sometimes the size of countries in this big nation. And people have been talking about, in the Western world in particular, about the deficiency of doctors in our country. Yes, there is in totality, if I see the doctors' distribution is less. But when we start looking in terms of distribution of it, probably there is a skewed deviation. So they're more concentrated in the cities and rural areas there. And the good part, as far as in the country, as of in India today, is what we are seeing is the spectrum of COVID-19 we are seeing in the places where we had a very high incidence of swine flu, that is the urban area. I can give you a comparison. What is happening in the Delhi in the cancer patients who are getting the cases, 20 to 30% coming positive in certain hospitals. But when I look at my regional center, which is catering to nearly 500 to 600 cases per day, we only have 2 positive. And probably when we looked at the difference, it is realized that predominantly in India, still the disease continues to be urban rather than passing on to rural area. Similarly, we have been also talking about the beds or critical care beds, 2.3 per 1,000 population. But if you see it also, United States, Italy, which have a very large population, large number of ICU beds, still they had a challenge, because this is what we had started looking right in the beginning from. Because if there is a deluge, there is a search, we calculated, we did a mathematical modeling, how are the number of patients are going to. From the Western world, we calculated that nearly 30% people will be symptomatic. And out of 30% people, if we look at it, there will be probably, out of these 100 patients, 10% may be requiring oxygen or ventilator. That's how we calculate it. But still that number, because of population, is like a city of Delhi, which is a population nearly of 2 crores. You will see 20 million, the number goes jack up. And that is the reason people talking about 2 million to 3 million cases coming up in Delhi over a period of time. But fortunately, we are seeing increase in the number, but till now, we are holding on. And by and large, there has been a challenge for us with critical care beds, but the government has expanded. The private sector has also come into it, which is taking care of it. But yes, definitely, we have some shortage. So we are trying to provide in the National Capital Region a strategic depth, same as happened in Mumbai as well. We talked about the number of ventilators, and I know there has been talk about less number of ventilators. I go by the thing, what you've seen in Italy, what you've seen in UK, or what you have seen in USA, particularly in New York. The mortality of the patients who have gone on ventilators have been very high. So probably this something has been very skewed. I was discussing it with my colleagues in UK, and we have written a commentary for one of the major leading Republic, where we were talking about what use is when you do not have a basic infrastructure, or people who do not know how to use ventilators. Therefore, what we realized at that point of time is that it is the oxygen supply which is far more important than actually your ventilators, because majority of your patients will be needing oxygenation when they land up in a trouble, rather than looking at the ventilators all the time. And we have been trying in this country augmenting oxygen supply vis-a-vis demand, which is there. And obviously, we have a very diverse system in this country of cylinders, manifold systems, concentrators, and liquid oxygen. My own institution, we have 3 different liquid oxygen plants to supply and to supplement it. The government, and we have done it, more than 1,000 D-type cylinder. That means we have created, if we look at it, each cylinder roughly equal to more than 10 KL capacity. We have created, as far as the mobile liquid cylinders, we have also done it, so that if some problem occur, we do it. So that's a very big challenge which was taken by the health administration across states as well as the government of India. And probably, I think, we have diverted a lot of this oxygen which was in the industrial area to your medical oxygen. And this gives you an idea. When the epidemic started, India hardly used to make 25 to 50,000 PPE. Today, as of today, within 4 months of it, we are manufacturing, as of today, per day, nearly 2 lakhs, which have been expected to go up to 1 million per day. Initially, we had an issue of quality, but today, I can vouch with you, within the span, the way the industry has changed, we are finding a large number of PPE that the government has given a confidence to the government of India that yes, we can go and export. Same has been true not only for the coveralls or the wrap-ons, but same is true also for the goggles, for the face shields, as well as also for the N95 mask. Same has been oxygen cylinders. So these 3 to 4 months has given us a huge time to do it. It may not be sufficient, but it has given us enough confidence to deal this. When you start looking at the best practices, when we started as far as the diagnosis is concerned, a lot of my friends have talked, but we have all the facilities today for molecular detection, antibody detection, as well as antigen detection. Antibody detection, we have left altogether because of the kits which we got it from various parts. They did not do very well in the field testing. Molecular detection is the mainstay. And when we started, we just had the capacity of 10 to 15,000. Today, we are doing more than 3 lakh tests a day. In my own state, which is surrounding state of Haryana, when we started, we had 2 labs. Today, we have, as of now, 12 laboratories having a capacity of doing 10,000 RT-PCR per day. Same way, antigen detection has come into picture now. It is undergoing field trials. And what we are seeing is dominantly we are doing RT-PCR. Similarly, we have now looking at the TrueNet and CBNet, which again are things which are being used for the TB diagnosis. They have been now diverted afternoons in terms of diagnosis. So what the strategies we are following it up and is, I will come to that later, but if you see today, as of now, we have 1,047 operational labs having a capacity to do nearly more than 2 lakh tests a day, and it is still being augmented every day. Like in my small state, we are going up to a level of doing 30,000 tests, and today I can say with a sense of pride that we are done more than 10,000 tests per 1 lakh people. So we are going very strongly on it and picking up the cases. There are challenges there everywhere, but government has come up very well, and we have upgraded the lab skills as well as the lab infrastructure in our country. Obviously, when you start looking at antibody detection, I told you that the rapid antibiotic tests were a failure here, but we have now got a camelosense test, and we started detecting quantified immunoglobulins. Myself also went through a COVID. I had a COVID, and today I got my antibody tested, and I can say, yes, I have got a pretty good T-test now. And we are using in serosurveillance, which has started, and the serosurveillance, which was done in the month of May and April, it clearly showed us that, yes, there is a challenge. But what we found, except for few areas which I discussed to you, still we are not having community transmission. Primarily, it is in the cities of where the metropolitan areas where we are seeing some evidence of community transmission. But when I go to the rural area, still we are not finding it. So what we are doing today is, ladies and gentlemen, is we are first now making a plan, which has been ICMR has also proved it and has come up with a revised plan. We are going to do an antigen test. If it is a positive, we are going to take it as a COVID case. If it is a negative, depending upon the urgency which is needed and required, and the urgency will be an emergency surgery, labor rooms, and sometimes we are facing an issues with the dead bodies which are coming up. At that point of time, we will be using CBNet, TrueNet, and results will be there. And no urgencies, we are going with RB-PCR. CT chest, we are not put into any algorithm, but I think what we are trying to do is anybody who is sick for 5th to 7th day and has a cough or desaturation on exercise or after doing activity, we are taking them up. And we are extensively now, at least in the private sector, but in the government sector also, and the public sector, we have started using more and more CT scans to pick these cases early. As far as the best practices in the treatment is concerned, obviously, if you all aware about the timeline, we are following this now, because what we have realized in India from the literature which we had it with our own experiences, it is the timeline of COVID disease which is the key. So once you have an exposure, you have an incubation period, you have an onset of symptoms or pre-symptomatic phase, it is important for us to realize to pick these patients early. So it is the 5th to 8th day. When you start getting immune responses, that is the time we are seeing large number of people are having a problem. Catch hold of them, look at the cytokine storm, treat it, and if you are not going to do it, death is going to be there. Again, I'm sharing experience of this. I will come to that. When you look at a COVID-19, I am putting my neck out and say it's a steroid responsive disease, and the timing is important, because in the initial phase it's a viral replication, and later phase it is immune dysregulation. And what we are doing is that in these cases we are trying to keep them young. And I can give you an example of my institution where I'm practicing. Till we started practicing this, we had 27 deaths. But since we started multidisciplinary rounds and we're looking at it more vigorously, in last 3 weeks, we only lost 5 patients. And one of the major differences which we saw was the use of steroids, whether it's methylprednisolone or dexamethasone, we have been using it at this point. And also we have been very commonly now, we have used tocilizumab in nearly 60 patients, which is an IL-6 inhibitor. And we found where we give it early, only out of 16 patients where we gave it, 2 died. But again, that we are going to come up with our data. That is what we are using with. HCQ has been taken away from the moderate and severe, but in mild cases, yes, we are still using it. There have been other drugs like ivermectin, etc. Favipiravir has been approved, but we have a very little experience as of now. Vitamin C, zinc, people are using very regularly, and also the traditional Indian medicine. And managing hypoxemia for us, we were fortunate enough that we don't have to struggle that, but yes, there was a learning curve. And what we are using predominantly, we are using in these cases, high flow nasal cannulas, non-breathing mask, and if need be, CPAP and NIV, primarily with the full face mask, and when helmets are available with it. And obviously, awake proning is become a rule than an exception with us if person is not doing well for us. Convalescent plasma therapy, this is a young boy who just donated us the convalescent plasma. It has been approved for the compassionate and emergency use by a ministry, by the government of India. And we have nearly collected 600 data is expected anytime from the ICMR study. And whatever the little bit offhand I have an information, it has been found to be promising. And the Mayo Clinic data, which was published, also said it is safe to give it. But nevertheless, what is the biggest challenge is to do specific immunoglobulin levels in these cases. So what we are doing today, my dear friends, is that we look at it whether the patient is asymptomatic or minimal symptomatic without breathlessness. We look at the CXR if the person is in the hospital and look for oxygen saturation. They are being regularly put on home quarantine, but with a very intense pulse oximetry. That's what we are doing it. And we are using digital technology of an Arogya Setu, which is an app which is mandatory like a wristband, which was shown to by our previous speaker from Rwanda. And if there is a problem, they are pushed back to the hospital. On the other end, as I said, we are monitoring the inflammation very closely. We have built up our capacities and still in the process of building up. And wherever it is there, we are using steroid the first line, followed by plasma where it is available. And obviously, sometimes in the trial or otherwise, we are not hesitating in using tocilizumab. On the other end, antivirals, remdesivir was not available to us. We were using a combination of lopinavir. We added ribavirin now. Remdesivir has become available, and we have used in now 3 cases, at least in our institution, and now it is becoming readily available, and we will come up with the moderate disease, what is there. As a president, we had written the position statement. This has become the mainstay along with ICMR in most of the intensive case setting, the protocol which we are following. Home isolation I picked up. As I said, it is a supervised through, we called as an Arogya Setu. It's a Hindi application. And breathlessness pulse oximetry we are giving everybody. Every day we are calling these patients twice a day so that we know something is not going wrong. And any person who has got a breathlessness, fever, and cough is being asked to report. Therefore, what is important for us is an ounce of prevention is worth a pound of cure. That's what Benjamin Franklin said. So adequate PPE, as I talked about, the biggest challenge I'm finding is infection control practices. But I hope this is a universal thing throughout the world, and we need to keep on reinforcing it. And this is something which is very different from the word data. We people have been on hydroxychloroquine for prophylaxis. I myself was taking hydroxychloroquine. And what we are showing here in this data, if you see it in the ICMR, which has been public domain now published, that it starts becoming effective after 4 weeks of therapy. And I will be very happy to answer any question of it. And again, the people who are taking it, it's not saying that it will take you away from the infection, but probably it will reduce the complication which you are seeing are responsible primarily for the death from SARS-CoV-2. The challenges are the population. It's the poor awareness sometimes about the people, especially the poor, even if they are aware, because of the day-to-day things which are required for their livelihood is a challenge. Unemployment has become a very big issue with us because of job loss, migrant workers, transported jobs. Challenges are preventive. We are already going for a vaccine. BCG trial is there, mycobacterium trial is there, so is MMR. But vaccination, we are going to start trial from next week, which is a whole killed vaccine viron, which is there. Let's see what data comes up. Phase 1 is going to come up, and 10 centers have been identified, and we are going to recruit patients soon. But the most distressing part of it is the stigma which has been associated with it. And the net result is that people are concealing symptoms. They have a hesitancy in seeking medical care, and they're not adhering to intervention, and we may have to use sometimes forceful measures. So that's a very big problem of stigmata and discrimination. So when we looked at the medical professionals, you will see nearly 1/3 were depressed, 40% were having anxiety, and 1/3 was stress. And I'm sure this must be throughout the world. And that is where the article, this was published in European Heart Journal, which talked about lessons from Bhagavad Gita, from the land of Gita, from where I'm speaking to you, is actually from there. And what they say, which is important for the medical professional, is to be able to do what is needed without becoming attached to the result is the way of living a skillful life. And that's we are trying to practice it, telling our healthcare workers to come because of the scare and the panic, there was a lot of confusion to manage these cases to begin with. And again, this is an article which has been published in Lancet. With today's crisis, what Gandhi would have done it, he would have begun with actions which were initially small. So we need to look local, we need to look small. I'll start working from there. We need not merely preach, but we need to act and practice ourselves. We need to act locally, not chase the word to change. And I hope it is important everywhere. This is a young girl 10 year which made as a part of collage, which signifies what we are practicing in this country. We are asking people to stay home. We are asking for quarantine. We're trying to tell you, built up new things, new ways. And I would like to acknowledge quite a few people who have helped me in making this. Dr. Rajan Sharma, President of Indian Medical Association, and people from Ministry of Health, my own university and faculty and fellows of pulmonary critical care medicine. Thank you very much for patient listening.
Thank you very much, Professor Chaudhry. Again, another very...
Insights from the world's best medical minds. You are watching TheRightDoctors.com.